Most unintended pregnancies don't begin with recklessness. They begin with misunderstanding. Some believe that without orgasm, pregnancy is impossible. Others assume that if a male partner does not climax fully, the risk disappears. But biology doesn't wait for pleasure. Fertilization requires sperm and an egg, not fireworks. Many underestimate the power of a single encounter. It was just one time, they say. But if that one time aligns with ovulation, the odds shift dramatically. Others leave it to God's will. In communities shaped by religious fatalism, contraception may feel like defiance. But faith and foresight aren't enemies, they're allies in autonomy. Withdrawal is trusted more than it should be. Pre-ejaculate can carry sperm, and timing isn't always precise. Yet overconfidence persists, especially when sex education is absent or stigmatized. And then there's the silence around ovulation itself. Many don't track it, don't understand it, or believe it's rare. But the fertile window is real and it's often misunderstood. It's the hidden bias of the fertile window. We often imagine pregnancy risk as a clean roll of the dice, an isolated act, a statistical chance. But biology isn't passive. Ovulation doesn't just release an egg. It orchestrates a symphony of hormonal shifts that elevate sexual desire, emotional receptivity, and relational intensity. The fertile window isn't just when pregnancy is possible, it's when sex is more likely to happen. This means the probability of conception isn't merely about timing, it's about selection bias. We don't randomly land in high-risk windows. We're nudged there by internal cues we rarely recognize. Estrogen and luteinizing hormones surge, boosting libido and subtly shaping behavior. So when sex occurs during peak fertility, it is not just coincidence, it is biologically primed convergence. And if that encounter is unprotected, the odds aren't just elevated, they're engineered. Fertilization becomes likely. Implantation becomes possible. And the narrative shifts from theoretical risk to embodied consequence. Emergency contraception is another casualty of confusion. Some equate it with abortion, delaying its use until it is too late. These aren't just gaps in knowledge. They're gaps in systems, in storytelling, in support. Even the word conception carries semantic weight. Medically, some define it as fertilization the moment sperm meets egg. Others define it as implantation when the fertilized egg embeds in the uterine lining. This distinction matters because some contraceptives, emergency pills, work wholly by preventing fertilization, with weaker consideration of implantation prevention through uterine adaptations not explicitly determined, which are also ethically fraught to test for experimentally. But with copper IUDs, the evidence is well supported. Their primary mechanism is to prevent fertilization altogether. Once inserted, the copper ions released into the uterus create a localized inflammatory response that is toxic to sperm. This environment impairs sperm motility, viability, and function, making it extremely difficult for sperm to reach and fertilize an egg. Even if fertilization occurs, the altered uterine and tubal environment makes implantation unlikely. That's why copper IUDs are also effective as emergency contraception when used within 5 days of unprotected sex. And for those who equate implantation with the start of life, that can feel indistinguishable from abortion. But the evidence shows that copper IUDs primarily act before fertilization, not after. Clarity is not the enemy of belief. It's the foundation of informed choice. To reduce unintended pregnancies, we must confront these myths not with shame, but with precision. Because when people understand their bodies, their cycles, and their choices, they do not just prevent pregnancy, they reclaim agency. Pregnancy is a deeply personal journey, and intentions can shift as circumstances evolve. In the United States, nearly half of all pregnancies are unintended. Of these, about 42% end in abortion, while the rest are carried to term or placed for adoption. Interestingly, while rare, some pregnancies that begin as intended are later terminated. These decisions are often driven by unexpected medical complications, fetal anomalies, or sudden life changes such as financial instability or relationship breakdowns. Conversely, many people who experience unintended pregnancies choose to carry them to term. This can be due to personal beliefs, lack of access to abortion services, or legal and financial barriers. Studies like the Turnaway study show that most people who choose abortion feel confident in their decision even years later. Regret is uncommon, and the decision is often rooted in a desire to protect future opportunities, family stability, or health. These patterns reveal a complex interplay between intention, access, and evolving life circumstances. They remind us that reproductive decisions are not static, they are shaped by the realities people face in real time. Unintended pregnancies and abortion patterns remain at the epicenter of public health, policy, and socio-cultural debates within the United States. The urgency of this topic is underpinned by compelling statistics revealing fluctuations in unintended pregnancy rates, complex contraceptive dynamics, significant behavioral risk factors, and evolving abortion demographics. These dynamics are inextricably linked with broader systemic, behavioral, and cultural determinants that shape reproductive health outcomes. This comprehensive report synthesizes the most current research and authoritative datasets from 2023 to 2025, meticulously exploring 6 key dimensions. 1. The total number of unintended pregnancies. 2. The proportion associated with no contraceptive use. 3. The segment stemming from contraceptive misuse. 4. Unintended conception under substance influence. 5. The profile and incidence of repeat abortions. And 6. The proportion of abortions among mothers with prior children. Throughout, interpretive commentary explicates what these statistics reveal about embedded structural barriers, behavioral drivers, and ensuing public health implications. United States unintended pregnancy, magnitude and historical trajectory. Total number of unintended pregnancies. Estimating the total number of unintended pregnancies in the United States requires robust and regularly updated data. Recent figures from the Centers for Disease Control and Prevention, CDC, and Guttmacher Institute report that, as of 2023, there are approximately 2.3 to 2.5 million unintended pregnancies annually in the United States. This suggests that nearly 45% of all pregnancies are unintended, a figure that, despite gradual declines through the last decade, remains persistently high relative to other developed nations. The relative proportion has shifted downward from earlier decades, when nearly half of United States pregnancies were unintended, reflecting some progress but with rates still deemed concerning by public health authorities. Analysis of data trends over the past 20 years reveals a marked, albeit uneven, reduction in unintended pregnancies. In 2008, the unintended pregnancy rate was estimated at 54 per 1,000 women aged 15 to 44. This declined to 45 per 1,000 by 2011, and, according to the CDC's latest comprehensive releases, hovered around 36 to 38 per 1,000 in 2021 to 2023. Yet, there is notable regional and demographic heterogeneity that suggests both progress and persistent disparities. States in the South and Midwest generally report the highest rates, while states such as Massachusetts and New Hampshire consistently demonstrate the lowest levels. Interpretive commentary. The sheer magnitude of unintended pregnancies, affecting nearly 2 million women each year, underscores the high stakes for reproductive autonomy, maternal and child health, and downstream social and economic outcomes. Declining rates partially reflect improved access to contraceptives and education, but the continued prevalence close to 1 in 2 pregnancies illustrates that significant systemic and behavioral barriers remain. These figures also illuminate the need to distinguish between types of unintended pregnancies, as circumstances vary between those who passively accept the risk versus those who actively attempt prevention. Patterns of contraceptive use and misuse among unintended pregnancies. Proportion of unintended pregnancies with no contraceptive use. Accurate delineation of contraceptive use at the time of conception is critical to tailoring effective interventions. National surveys and public health analyses indicate that 39 to 45% of unintended pregnancies occur among women not using any contraception in the month they became pregnant. The 2023 CDC Reproductive Health Report notes that 40% is a reliable recent estimate, with variation by age, socioeconomic status, and region. This group reflects a complex spectrum, including individuals with limited access, those facing personal or cultural opposition, lapsed users, or women underestimating their pregnancy risk. Importantly, the persistent segment of non-use strongly signals structural and behavioral deficits, whether due to cost, insurance gaps, restrictive policy environments, service closures, or social and familial pressure. Proportion of unintended pregnancies resulting from contraceptive misuse. Conversely, 55 to 60% of unintended pregnancies stem from imperfect contraceptive use, which includes both contraceptive method failure and user error, for example, missing pills, delayed injections, incorrect use of condoms. Guttmacher's nuanced breakdown attributes approximately 43% to inconsistent or incorrect use, with 12 to 17% due to intrinsic method failure, for example, failure rate of condoms or oral contraceptives even with perfect use. In particular, adolescents and young adults exhibit higher rates of inconsistent use, while lower-income women disproportionately cite financial, logistical, or relational constraints impeding regular or appropriate contraceptive practice. Data further suggest that lack of adequate counseling or follow-up contributes to higher rates of misuse. This table distills major patterns and serves as an interpretive anchor for the more granular qualitative discussion that follows. The statistics highlight both the breadth of the phenomenon and its layered demographic, behavioral, and policy dimensions. Interpretation and behavioral insight. The predominance of contraceptive misuse as a source of unintended pregnancies refutes the misconception that non-use alone drives risk. Imperfect use. The human element can be attributed to a range of factors: inadequate sexual health education, limited method choice, partner dynamics, and insufficient follow-up with providers. Behavioral economics research implicates present bias, which is undervaluing long-term consequences, impulsivity, and risk misperception, all aggravated by fluctuating life circumstances, such as relationship discord or financial stress. Cultural and policy backdrops further shape outcomes. In areas with robust provider counseling and public funding for contraception, such as Title X clinics, research shows lower rates of both misuse and non-use, underscoring the efficacy of community-embedded, equity-oriented programs. Conversely, restrictive policies and clinic closures not only increase non-use, but also compound barriers for those struggling with adherence. Unintended pregnancies conceived under substance influence. Scope and recent findings. An emerging and critical area relates to pregnancies occurring during periods of substance use, primarily alcohol, cannabis, opioids, and stimulants. Recent CDC and NASADAD reports indicate that 15 to 25% of unintended pregnancies involved maternal substance use within the critical 30 to 90 days surrounding conception. Among specific subgroups, including women with substance use disorders, rates may be substantially higher, reaching over 50% in some at-risk populations. Further segmentation reveals that alcohol remains the most prevalent substance, with approximately 13 to 20% of women reporting binge or heavy drinking in the weeks preceding conception. Illicit drug use, though less common in the general population, is disproportionately higher among young adults, racial and ethnic minorities, and those experiencing housing instability or intimate partner violence. Behavioral context and systemic contributors. Pregnancies occurring under substance influence frequently intersect with broader health inequities and social vulnerabilities. Substance use may impair judgment, disrupt contraceptive routines, or lead directly to unprotected sex. Studies show that women with substance use disorders report greater barriers to accessing both preconception counseling and reliable contraception, barriers exacerbated by stigma, mental health comorbidities, and criminalization of substance use during pregnancy. Public health experts highlight that substance-driven unintended pregnancies are not merely individual failings, but signal deep-seated deficits in community support, integrated behavioral health care, and harm reduction. The persistent criminalization of drug use in pregnancy, particularly in southern and Midwestern states, is linked to lower prenatal engagement and worse maternal-child outcomes. Repeat abortions, profile, prevalence, and underlying realities. Incidence of repeat abortions. Analyses of national abortion surveillance data and Guttmacher Institute research consistently indicate that 38 to 44% of all abortions in the United States are to women who have had at least one previous abortion. This rate is relatively stable over the past decade, despite overall declines in the absolute number of abortions nationwide. State and provider-level datasets echo these patterns. For example, 2022 CDC data found that 43.2% of abortion patients nationally had obtained one or more prior abortions. Repeat. Abortion is not synonymous with neglect or irresponsibility, a common stereotype, but rather reflects recurrent exposure to the same structural and behavioral risks that drive first-time unintended pregnancy. Among women obtaining repeat abortions, the majority are low-income, disproportionately women of color, and more likely to face housing, employment, or insurance insecurity. Behavioral profile and structural dynamics. The behavioral science literature suggests that many individuals seeking more than one abortion encounter persistent or recurrent life circumstances that restrict their ability to adopt effective contraception long-term. These include unstable relationships, ongoing intimate partner violence, chronic mental health challenges, and entrenched poverty. Repeat abortion is particularly common among women with young children, reflecting both the realities of family care and the calculation of economic and relational capacities to manage additional offspring. Statistical scrutiny discredits the notion that repeat abortions arise mainly from carelessness. Rather, repeat abortions often signal a lack of affordable, long-acting contraceptive options, ineffective or coercive partner negotiations, or episodic access to care following restrictive state immigration or insurance policies. Abortions among mothers with existing children. Proportion and trends. Perhaps the most widely misunderstood dimension of abortion in the United States is the demographic profile of abortion patients, particularly the incidence among women who already have children. According to Guttmacher Institute, CDC, and Pew Research Center analyses between 2022 and 2024, 59 to 63% of all abortion patients are mothers with at least one prior child. This pattern has remained consistent for decades. Detailed review of patient survey data indicates that 2/3 of abortion patients cite concern for existing children and family responsibilities as primary factors in their decision-making. The archetype of the childless teen seeking abortion is thus far less representative than public discourse suggests. The prototypical patient is frequently a mother in her late 20s, contending with economic instability or challenging partner dynamics. Sociocultural and behavioral insight. This reality upends common stereotypes and invites a deeper understanding of abortion in the context of family planning and maternal well-being. Many mothers seeking abortion cite their inability to afford another child or to provide adequately for existing children as the deciding factor, often in the face of precarious employment, unreliable childcare, or partner disengagement. In these cases, abortion is less a rejection of motherhood than a stratagem to protect familial integrity and security. Moreover, the high proportion of mother patients accentuates how policy debates, particularly surrounding restrictions, are both gendered and classed. The burdens of additional child-rearing without adequate social supports fall disproportionately on women of color and those in low socioeconomic status groups, reinforcing the structural nature of abortion demand. Layered behavioral and demographic insights. Who is most affected? Demographic breakdown: age, race, and socioeconomic status. Unintended pregnancy and abortion are not evenly distributed. Younger women, ages 18 to 24, continue to exhibit the highest unintended pregnancy rates, though rates for teens have declined over time due to advances in contraceptive access and education. Black and Hispanic women experience unintended pregnancy at double the rate of white women, a disparity closely tied to systemic inequities in insurance, provider bias, transportation, and comprehensive sex education. Low-income women are at greatest risk, with the poorest quintile reporting an unintended pregnancy rate nearly 5 times that of the wealthiest quintile. These patterns reflect not only economic constraints, but also differences in agency, exposure to coercive relationships, and cumulative stress. Geographic variation. Geography functions as a powerful determinant in reproductive outcomes. Southern and Midwestern states dominate the rankings for highest unintended pregnancy and abortion rates, while New England and the Pacific Northwest showcase the lowest levels. State policy landscapes ranging from Medicaid expansion and contraception mandates to abortion clinic regulation shape access and outcomes. States with robust Title X programming and Medicaid coverage for family planning report consistently better indicators across almost all metrics. Systemic barriers to effective contraceptive use. Systemic obstacles undermine the translation of contraceptive intent into effective use. Chief among these are insurance gaps, particularly following Medicaid churn, clinic closures, restricted formularies, and cost-sharing requirements that dissuade method switching or upgrades. Rural populations face provider shortages and longer travel distances, exacerbating delays and discontinuity. Additionally, restrictive state policies on sex education and parental consent further encumber adolescents and marginalized populations from obtaining adequate contraception and counseling. Implicit bias and provider stereotyping often discourage patient disclosure and method satisfaction. For instance, research demonstrates that Black women are less likely to receive comprehensive contraceptive counseling and more likely to report skepticism stemming from medical mistrust, a consequence of historic and ongoing reproductive injustice. Analysis of behavioral drivers and public health implications. Behavioral drivers. A. Knowledge and risk. Perception, gaps in sexual health education and risk assessment remain prominent. Even in states with formal sex education, content deficiencies or abstinence-only curricula diminish the efficacy of message retention and understanding. Many women and adolescents underestimate their personal pregnancy risk or are misinformed about fertility timing and contraceptive method effectiveness. B. Partner influence and coercion. Behavior is further shaped by partner attitudes and relationship power dynamics. Reluctance or opposition from male partners to contraception is a cited barrier by 25 to 40% of at-risk women, influencing both use and method selection. Intimate partner violence correlates with higher rates of both unintended pregnancy and abortion, as coercion undermines voluntary, consistent method use and the ability to negotiate safer sex. C. Economic and social instability. Unpredictable employment, child care responsibilities, and housing status contribute to missed appointments, gaps in insurance eligibility, and competing priorities that lower adherence to prescribed contraceptives. These stressors exacerbate impulsivity, present focus, and decision fatigue, all of which can drive non-use or misuse. D. Substance use and mental health. The overlap of substance use and depression, often co-occurring, disrupts routines, impairs judgment, and diminishes capacity to access or consistently use contraception. Mental health comorbidities amplify these cycles, leading to elevated risk clusters in vulnerable subpopulations. E. Cultural and religious influences. Deep-seated cultural beliefs and stigma around contraception pervade certain communities, fueling non-use or preference for less effective traditional methods. Mistrust of medical institutions and provider bias further amplify these effects, especially among immigrant populations or those with histories of reproductive coercion by the state. Public health implications. The persistent prevalence of unintended pregnancies has far-reaching consequences. For individuals, such pregnancies are correlated with delayed prenatal care initiation, lower birth weights, higher risk of maternal depression, exposure to interpersonal violence, and poorer developmental outcomes for children. Health system costs are substantial. The Centers for Disease Control estimates that unintended pregnancies add billions in direct healthcare expenditures each year, with disproportionate impact on publicly funded programs like Medicaid. At the community level, regions with high unintended pregnancy rates face amplified cycles of poverty, reduced educational attainment, and greater child welfare involvement. The high incidence of abortion among mothers with existing children flags acute gaps in public policy to support family formation, parental leave, and childcare provision. Abortion bans and the post-Dobbs legal landscape have further exacerbated these risks. States with tighter restrictions report upticks in unsafe self-managed abortion attempts, travel burdens, and second trimester procedures, with marginalized populations bearing the brunt of increased stigma and reduced access. In the wake of increased restrictions since 2022, some states have witnessed rising unintended pregnancies alongside decreased abortion rates, with resultant increases in adverse perinatal outcomes. Conversely, robust investments in comprehensive sex education, easy access to a full range of contraceptive methods including long-acting reversible contraception, seamless insurance coverage, culturally concordant counseling, and integrated behavioral health have been shown to dramatically reduce both unintended pregnancy and abortion rates. Integrated synthesis, interpreting the interconnection of data and behavior. Synthesizing the broad array of epidemiological and behavioral data, several themes clearly emerge. First, the majority of unintended pregnancies in the United States reflect not a singular point of failure, but a dynamic interaction between socioeconomic vulnerability, systemic deficits, and individual-level behavioral patterns. The high percentage of unintended pregnancies among women with consistent contraceptive intentions but hampered by user error or disruption emphasizes the need for multidimensional support. Second, the prevalence of repeat abortions and abortions among mothers must be decoded through the intersectional lens of poverty, parenthood, and caregiving responsibilities. Far from the stereotypes, these are pragmatic decisions often rooted in resource protection for existing families, compounded by inadequate workplace flexibility, childcare infrastructure, and affordable health care. Third, the link between substance use, unintended pregnancy, and abortion waves off a punitive approach in favor of holistic models integrating harm reduction, mental health, and reproductive support that recognize the deeply embedded, interlocking determinants faced by these women. Lastly, cross-state variation in both unintended pregnancy and abortion statistics are not merely epidemiological quirks, but the measurable consequences of divergent policy environments. States that invest in comprehensive supports from Medicaid funding to robust Title X programming and non-restrictive abortion laws consistently demonstrate better reproductive health outcomes for all women but especially for the most marginalized. Conclusion: what do these patterns reveal about systemic barriers and public health? The synthesis of current U.S. data and behavioral research on unintended pregnancies and abortion unmistakably reveals a landscape shaped far more by structural, systemic, and social determinants than by individual volition alone. The statistics, while sobering, are critical indicators of systemic performance. Unintended pregnancies signal the failures of policy, access, and education. High rates of contraceptive misuse reflect gaps in provider-patient encounters, systemic inequities, and broader cultural ambivalence. And the prevalence of repeat abortions and abortions among mothers reveal unaddressed needs in family support and reproductive justice. Public health frameworks increasingly view these outcomes not only as clinical challenges, but as barometers of social welfare, gender equity, and economic opportunity. Interventions, whether at the policy, community, or health system level, that expand equitable access to information, services, and supports, stand to radically reduce the rates and adverse consequences of unintended pregnancy and abortion. Moving forward, targeted public investments in universal, evidence-based sex education, accessible and affordable contraception with a focus on long-acting methods, culturally competent care, and social supports for parents will likely yield the twin dividends of improved health and upstream cost savings. Fundamentally, confronting the challenge of unintended pregnancies and abortion in the United States requires not solely a medical or moral strategy, but a multi-layered commitment to reproductive autonomy, socioeconomic justice, and holistic health. A project still very much in progress, but essential for the nation's collective well-being. The Prevention Arc, a Common Ground Vision. In a world often divided by ideology, one truth remains universal. No one wants to face an unintended pregnancy without support, knowledge, or options. This is the Prevention Arc, a layered, compassionate system designed not to take sides, but to reduce the need for difficult decisions in the first place. We begin with access. Every person, regardless of belief, background, or circumstance, deserves free, timely access to modern contraception. Long-acting methods, barrier options, emergency contraception, all offered without stigma, delay, or judgment. We embed education early and often. Not just anatomy, but consent, cycle literacy, and contraceptive stacking. Because when people understand their bodies, they make choices with clarity, not crisis. We normalize dual and triple method use not to push ideology, but to protect futures. An IUD plus condoms, pills plus withdrawal. Redundancy becomes resilience, and resilience becomes prevention. We layer in cycle tracking tools, trauma-informed care, and substance use support because unintended pregnancy isn't just biological. It's emotional, social, and structural. And we build economic scaffolding, childcare, housing, mental health care. Because the decision to continue or end a pregnancy should never be dictated by poverty or isolation. Finally, we ensure that post-abortion care is universal, non-coercive, and rooted in dignity. Whether someone chooses to continue a pregnancy or not, they are met with respect, not rhetoric. This isn't pro-life. It isn't pro-choice. It's pro-prevention, pro-compassion, and pro-humanity. It's a system where fewer people face unintended pregnancies and more people live with autonomy, support, and peace. This is the prevention arc, and it's how we move forward together. In a world shaped by assumptions, one statistic often goes unquestioned, that just 1% of pregnancies are unconsented. But the reality is far more complex and far more urgent. According to Planned Parenthood's 2015 consent survey, nearly 1 in 3 adults reported having experienced a situation where they were unsure if what happened qualified as consensual. And 1 in 5 said they had engaged in sexual activity because they felt pressured, not because they freely chose to. This isn't fringe. It's foundational. That's why the prevention arc must include a consent spectrum framework, one that recognizes that coercion, manipulation, impaired judgment, and relational imbalance are not edge cases. They are part of the landscape. We build systems where male cohesion is not optional, where men are not passive participants, but active stewards of prevention and consent, where contraception is shared, not outsourced, where silence is not mistaken for agreement. We embed relational literacy into every layer, understanding power dynamics, emotional pressure, and the difference between compliance and true consent. We normalize conversations about contraception, boundaries, and shared responsibility starting early, reinforced often. We invest in Planned Parenthood not just as a clinic, but as a cultural infrastructure where pregnancy is planned, mutual, and informed, where no one ends up pregnant because someone else opted out of responsibility. And we name what is often unnamed, that many unintended pregnancies are not fully consensual. Not because of violence alone, but because of systemic gaps in education, autonomy, and relational equity. This isn't about blame. It's about building a system that sees the full spectrum of experience and responds with care, clarity, and prevention. The prevention arc is not just medical. It's emotional. It's cultural. It's structural. And it's how we move from reaction to revolution. The prevention arc, naming the unseen. There's a story we rarely tell. A story not of choice but of coercion disguised as care. While public narratives often frame abortion as a freely chosen act, the truth is more layered. A 2023 peer-reviewed study found that nearly 70% of women who had abortions described them as inconsistent with their values or unwanted, with 24% explicitly coerced. This is not rare. It's a hidden epidemic. Forced abortion doesn't always look like violence. Sometimes it is a partner saying, "If you keep this baby, I will leave you." A parent threatening to cut off education. A friend making the appointment without asking. A system offering no financial support, no housing, no safety net, just a quiet push toward ending what someone wanted to keep. This is not freedom. It's reproductive sabotage. The prevention arc must name this. It must protect the right not just to avoid pregnancy, but to continue it without coercion. It must include legal safeguards, trauma-informed care, and cultural accountability. Because no one should be forced to end a pregnancy they wanted, whether by threat, manipulation, or silence. We must build a system where choice is real, not rhetorical. Where support is tangible, not conditional. Where every pregnancy is met with respect, whether it ends or continues. This is the prevention arc. And it's how we protect autonomy, not just in theory, but in practice. Narration, the prevention arc, beyond birth. We often speak of maternal health as if it ends at delivery. But for too many, the danger begins after birth. In the United States, hundreds of mothers die each year not from hemorrhage or hypertension, but from H-slide and S-slide. These are not statistical outliers. They are the leading causes of maternal death outside of obstetric complications. According to national data, over 800 maternal homicides occurred in recent years, most involving firearms, many unfolding in homes meant to be safe. And more than 500 mothers died by S-slide, with the majority over 60% occurring months after birth, long after the last clinical checkup, long after the casseroles stop coming. This is not just a failure of medicine. It's a failure of systems. We must build a maternal health framework that extends beyond delivery. That recognizes the late postpartum period from 6 weeks to 1 year as a time of heightened vulnerability, where mental health screening is not optional and relational safety is not assumed. We must name what's often unnamed, that maternal suicide is preventable and maternal H-slide is predictable, that both are shaped by trauma, isolation, and systemic neglect. The prevention arc must include firearm safety, partner accountability, and extended care pathways. It must see mothers not just as patients, but as people navigating complex emotional, relational, and economic terrain. Because maternal health doesn't end at birth, and neither should our care. This is the prevention arc, a system that protects life not just in the womb, but in the world. Shared ground in prevention with room for divergence. In the landscape of reproductive health, the conversation often divides pro-life and pro-choice, autonomy and protection, rights and responsibilities. But beneath the surface, there's a quieter truth. Most people, regardless of ideology, want fewer unintended pregnancies. They want fewer moments of crisis. They want more informed choices, more compassionate systems, and more respect for the complexity of human experience. Sexual education isn't just about anatomy or contraception. It's about building partnerships across belief systems. Pro-life advocates may emphasize the sanctity of life from conception. Pro-choice voices may center bodily autonomy and the right to decide. And while both can agree that prevention matters, it's also true that these foundational differences shape expectations in intimate relationships. For some, abortion is never an option. For others, it is a necessary safeguard. These aren't just abstract positions, they're lived values. And when they collide in a partnership, the stakes are high. Sexual selection, whether conscious or intuitive, often reflects these deeper alignments. Compatibility isn't just about chemistry, it's about shared frameworks for risk, responsibility, and response. So while education can illuminate common ground, it can also help individuals recognize where divergence matters. Not to divide, but to clarify. To empower people to choose partners who reflect their values, respect their boundaries, and understand the consequences of shared decisions. Because in the end, prevention isn't just a method, it's a mindset. And when that mindset is shared, the outcomes are better for everyone. The arc forward. We've mapped the terrain layer by layer, truth by truth. From unintended pregnancy to postpartum risk, from consent complexity to male responsibility, we've built a system not of blame, but of possibility. This is not just a prevention model. It's a redefinition of care. It's a world where contraception is layered, not lucked into. Where consent is understood, not assumed. Where pregnancy is planned, not pressured. Where postpartum isn't a cliff, but a continuum of support. It's a world where men show up not just in conception, but in prevention, in planning, and protection. Where silence is no longer mistaken for agreement, and responsibility is no longer optional. It's a world where maternal deaths from S-slide and H-slide are not tragic inevitabilities, but preventable outcomes of systems that finally see the whole person. This is the prevention arc. And it's how we move forward not with fear, but with design dignity and shared resolve. Because reproductive health isn't just about avoiding crisis. It's about building futures. And the arc we have drawn does not bend toward ideology, it bends toward humanity.